more on the spread of misinformation about the coronavirus and the spread of the virus itself, let's bring in our guest. Dr. Gregory Poland is professor of medicine and infectious diseases and the director of the vaccine research group at Mayo Clinic. And Dr. Scott Gottlieb is former FDA Commissioner and now a CNBC contributor who is also a member of Pfizer's board. Dr. Gottlieb, I want to start with you and just try and get the numbers on the ground. You were with us last week and said at that point it was probably too late to stop the spread in China, but perhaps it was here. What do you think about the increased numbers we've since heard?
Well, I think we need to change our posture here in the United States. I think we need to have a posture where we're going to try to detect outbreaks early, and that means broadening the screening criteria and broadening the capacity to do screening here in the United States. Right now, the posture seems to be focused on preventing introduction of the virus into the United States. That's helpful, but we have to assume it's already here and circulating. What we want to do is spot outbreaks early and step in to take measures to prevent small outbreaks from becoming larger outbreaks and an epidemic.
How do you do that? I thought the CDC were the only ones who could actually do the testing on this.
Well, that's just it. The CDC should broaden that test to public health agencies and local labs, maybe even hospital labs. It's a simple PCR-based test. A lot of people could run it. We also should change the criteria for screening. Anyone who's presenting with an atypical, a bad pneumonia that has a negative screen on what we call the multiplex test for viral forms of pneumonia, and it's a suspicious case, they should probably get tested even if they
haven't been to China.
Even if they haven't been to China, because what's going to happen is, in a setting of an outbreak, it's going to be secondary spread. It's not going to be someone who visited China who gets sick. It's going to be someone who interacted with someone who visited China who is sick and maybe asymptomatic or had mild illness. That's how we're going to spot an outbreak. Right now, if you believe that about 10 to 20% of people develop pneumonia, so it's only a small fraction will end up in the hospital. You might need dozens of cases in a city before you have enough suspicious cases showing up in any one institution to elicit testing. So you want to get that trigger earlier so you can spot small outbreaks, prevent them from becoming big outbreaks.
Dr. Poland, what are your concerns at this point? And I guess what's the upside? What do you think we're better at doing now than we were when SARS came out?
Yeah, first of all, I absolutely agree with Scott and his recommendations there. We need to be clear. We're basically at a pandemic now. And what we need to be doing in a situation like this is we need, number one, point-of-care diagnostics, which is what Scott was referring to. We need to have a lower threshold for doing that. And, remember that SARS was controlled basically with very low tech, but high efficacy measures like hand washing, social distancing, wearing masks, et cetera. So that's what we really need to be focused and concentrated on now.
I think what we should be trying to do here is buy time to get to the spring and summer when the epidemiology of spread might change, and hope that the summer is a backstop. It might not be a backstop because this is so novel. People don't have any cross immunity. It might still transfer into summertime, but we should hope that that's going to be a backstop.
You're talking about the summertime. But let's talk about the economic impact for a second. If you're trying to wait till the summer, what else are you going to have to shut down between now and then?
Well, look, I think the next 2 weeks are pivotal. If we don't start to see outbreaks in the United States within the next 2 or 3 weeks, we might have dodged the bullet here. I think we're going to start to see secondary spread in the United States in the next 2 or 3 weeks.
And then what?
And then it's going to be a difficult month. I think people are going to start to shut down, certain activity to try to curtail the spread of this. The good news is probably that people are sufficiently concerned that I think we will be willing to take measures that will be necessary to stop this from becoming a bigger epidemic in the United States.
Can we talk about a real physical example?
It's early.
Go ahead, finish your thought. Yeah, go ahead.
Yeah, it's early, but we've had very limited second-generation cases as opposed to other areas like China.
Here in New York, for example, a lot of the Chinese immigrants moved to Flushing, Queens. So if you take the 7 line out there, there's a lot of people wearing masks. Is that something that people in New York should consider doing just generally or no?
Masks have limited usefulness. I mean, a simple surgical mask is going to get moist in a small amount of time. It's only useful for 10, 15, 20 minutes.
Really?
An N95 mask, an N95 or N100 mask is more useful for a longer period of time. Most people aren't using that. They're using nurses' masks if you look at what they're wearing. I think the best value of a mask, frankly, is it prevents people from touching their face, because this really transfers through the conjunctivitis. So people touching something and then touching their face. So if they have a mask on and they're less likely to touch their face, they're doing some good.
Yeah.
Dr. Poland, you point out...
the advantage is behaviorally.
Exactly.
You point out that since SARS, the amount of train travel in China is up tremendously, the amount of air travel, and you could probably say the same thing around the globe. We are seeing people travel much more frequently.
Well, that's really what makes this of concern. Number one, you've got a novel virus that can infect humans. We don't really understand its reproductive number. We don't really understand the case fatality yet. The number of cases that you're hearing about, over 17,000 today, is absolutely an underestimate. Those are the more severe ones that we know about. What that real denominator is, we don't know. And as you point out, unprecedented in the history of mankind has been the level of travel. In 1 week in China, there were about 2,300 flights at the beginning of January out from China to the rest of the world. That's a lot of people moving around.
It's an excellent point. I mean, we know the numerator. We don't even really know the numerator because China is under testing right now from what I'm hearing. But we definitely don't know the denominator. There's probably tens, if not hundreds of thousands of cases in China. So when you start to factor that in, the case fatality rate isn't 2%. It might be more like 0.5%. Right. But even that would be devastating if there are not. The transmissibility is 2 to 3 new cases for every 1 case. If you have something that has a case fatality rate of 0.5%, the flu is, by comparison, 0.1%. So it could be devastating.
It's even smaller than that. I mean, if you look at 15 million people who had influenza here in the United States, you have 8,000 people who died. I think it's closer to a 0.005%.
Well, remember, this could burn its way through a population more efficiently. We don't have any cross-immunity, no vaccine, no backstop. I'm sorry, doctor.
Yeah, no, that's right. I was just going to say, you know, the updated numbers of influenza are an estimate of about 25 million that have been infected, somewhere around 20,000 that have died this season in the U.S., and another 200,000 to 300,000 that have been hospitalized. So, you know, you kind of compare the two. What Scott was getting ready to say, and is absolutely right, is this is a novel virus for us. This is an absolutely virgin population. We don't have any immunity to this, and that's why you tend to see somewhat more severe disease.